Guys, this is Mobeen. We are talking about arrhythmias. The lecture today is about the supraventricular arrhythmia and especially the premature beats and how to identify them, what to do about them. So objectives are, we'll go through the terms of the supraventricular arrhythmias. We'll then talk about various types of arrhythmias that can occur and why do they occur and what is the EKG shape difference that appears because of these arrhythmias. And finally, we'll talk about management. So terms, first of all, supraventricular extrasystole or supraventricular arrhythmia are the same thing. These are extrasystoles or extra beats that appeared on the EKG because of there is some ectopic rhythm generator in the atria. It happens in normal people. Once in a while it is possible, so you don't have to go and start fixing it. We all get extrasystoles here and there, so that's okay. But if it is a sustained extrasystole, that is, it keeps happening, then of course it needs management. Now, these extrasystoles are of two types: atrial premature contraction and junctional premature beat. The difference between the both are actually coming from atria, but the difference is if the premature beat is appearing somewhere in the atrial tissue other than the AV node and SA node, then it is atrial premature beat. And if the extrasystole is appearing because of a depolarization in the area in the vicinity of the AV node, then it is junctional. And why do we say it is junctional? Because AV node sits at the junction of atria and ventricle. So we have to understand these two. And finally, we'll see blocked junctional rhythm as well. So these are the three things that you would take away today. So first of all, the atrial premature beat. So remember, this means not junctional, atrial premature. It is supraventricular, but it is atrial. So what do we mean by that? What that means is there is a premature beat, that is, beat appeared earlier. And how would you know? The rhythm will tell you. QRS complex appeared, let's say if it was supposed to appear here, it appeared here. So that is the rhythm abnormality. Then if you look at the QRS complex itself and it is normal, that means ventricle and the conduction of the wave to the ventricle is normal. So that means it is a supraventricular problem. Then you focus on the P wave and see what is going on with the P wave. You will see some abnormality with the P wave and you would declare that as the atrial premature beat. If the P wave is inverted or P wave is absent, then you will call it junctional premature beat. So I'll explain why. But this is the summary of this lecture. So if you are just looking for review and you just want to know what are the EKG changes, here are the changes. The systole appeared earlier than it should be. That means it is a premature beat. QRS complex is normal in shape. That means ventricles are fine. The P wave is either abnormal or it is absent. That will mean it is atrial premature beat or junctional premature beat. Done. If you want to continue to understand why does this happen and look at some EKGs with me, then stick around and we'll continue. How about that for a quick review? All right, so now let's talk about atrial premature beat first. So what atrial premature beat means is that there is an extrasystole that appeared somewhere in the atria, but not at the level of SA node and not at the level of AV node. What will that do to the P wave? P wave's shape will change. Why will the shape change? Remember that if the depolarization starts from here and moves downwards, and instead of that, now the depolarization is starting here and moving this way, of course the P wave shape will change because P wave represents the electrical current in the atria. The other thing is axis can change, P wave's axis. So look, normally P waves goes from the SA node towards the AV node, but imagine now it is going from AV node towards SA node, so it has become reversed. So don't you think that the axis of the P wave will become reversed as well? Right? So depending upon where the depolarization occurred, the axis of the P wave will be accordingly changed. So in the case of premature atrial beat. QRS complex are normal, beat is earlier, and the P wave is abnormal. Contour or shape is abnormal, or axis is abnormal. So look at this. This is an atrial premature beat. Here, look at the beat number 2 and beat number 6. You can actually visually see that the QRS complexes, this seems to be a normal rhythm, this is normal rhythm, but beat number 2 appeared earlier and beat number 6 appeared earlier. But look at the QRS complex itself, it is normal. P wave almost seems normal as well. This is a hand-drawn EKG, so that is why P wave is normal. This is a supraventricular arrhythmia. We know that much because QRS complex is normal. Now, if the P wave is present, which in this case it is present, then it is not a junctional arrhythmia. So that means it is atrial arrhythmia. Ideally, there should be some change in the P wave as well that you can observe. Look at another example of atrial premature beat. This is not hand-drawn, this is an actual EKG. And here you can see that the QRS complex is present earlier than it should be. So it is premature. It is normal in shape, that means ventricles are fine. So this is a supraventricular arrhythmia. And in this case, I actually don't see a P wave, so this may be junctional. So I'll explain in a second that why absent P wave means junctional. So let's talk about it. This is junctional premature beat. So hope atrial premature beat is clear to you. P wave is present, the shape is wrong or the axis is wrong, and the QRS complex is normal. So that is atrial. Now in junctional, look at this, it's very simple. Look, normally the wave starts at the SA node and moves towards the AV node and then towards the ventricles. So this is the path. Imagine now that the wave is actually starting at the AV node vicinity. Where would the current go from there? It will go upwards in the atria and downwards in the ventricle almost at the same time, right? So if that will happen, look at these two arrows. The current is now starting in the AV nodal vicinity, moving upwards in the atria and spreading downwards in the ventricle. What do you think will happen? The electrical currents of both chambers are now superimposed. Because they're superimposed, will you be able to see the P wave? No. Why not? Because it got buried under the QRS complex, because ventricular action potential or current is stronger than the atrial. So QRS complex buried the P wave. So in this case, junctional arrhythmia, P wave is absent. Or if it is present, then what would you see? You would see an axis abnormality. Why? Look, normally the current goes this way. And when the P wave is appearing here at the AV node, now the current is going in reverse. So of course the axis, if the P wave is present, the axis has become reversed. So normally from SA node to AV node, look at this green arrow. So that is not happening. And now what is happening is the current is going in reverse direction. That would cause the P wave axis to become reverse. This is called a retrograde P wave. Retrograde P wave will be present in the junctional arrhythmia. It is absent if it got buried in the QRS complex. If it is present, it may have an axis deviation, axis change. So how would you identify the junctional premature beat? P wave is absent or it is axis is abnormal. QRS complex is normal, rhythm is abnormal. So now how do you differentiate? So we are done with the two primary types, that is junctional and atrial. Now some more bonus points. This is very important. The escape rhythm and the extrasystole, they look similar in the EKG except their rhythm. So we have to be able to differentiate between them. So let's talk about it. Look, how do you differentiate between a junctional premature beat versus escape rhythm? So here is how you differentiate. First, understand that what is the difference between them, or what is similarity. Similarity is that both can be started by the AV node. SA node somehow failed to conduct and AV node took over. That is common in both, which means the shape of the EKG systole is going to be the same. The impulse started from the AV node. It went upwards and downwards. P wave became absent or became buried. We just talked about it. However, this is what is interesting. If it is premature, then that will mean the QRS complex appears earlier. And if it is escape, that means SA node failed, AV node waited and waited and waited. Then it said, all right, I have to generate a wave now. And then it created a depolarization wave. So it will be, the QRS complex will be late. So absent P wave or inverted or retrograde P wave with a late QRS complex is the escape rhythm. And absent P wave or retrograde P wave with an earlier QRS complex is premature beat. That's it. That's the simple. So if you see here in this area, the P wave is present or slightly distorted, and here is a QRS complex. So this is early. Here, if you see, there is no QRS complex here. P wave should have appeared here. So this is a delay, which then is followed up by a QRS complex or a junctional rhythm. So this is the difference. Delay or early is the difference. Shape is going to be the same. Now one more thing, another bonus point, really important one, blocked atrial premature contraction. Ask your friends, hey, do you know what is blocked atrial premature contraction? So what does that mean? It is very simple. Let's say that the impulse extrasystole occurred somewhere near the AV node, and the AV node is still recovering from the previous beat. Remember, heart doesn't just stop, it just keeps having beats. So after every beat, the system repolarizes and recovers, and then it beats again. So imagine if the AV node is still recovering while the extrasystole appeared. Remember, it's a premature beat. It appeared before it should have. It didn't give other people a chance to rest, and it started again. So the beat started. AV node is not ready yet. Do you think AV node will conduct that impulse? No, it is not ready. So impulse got blocked there. This is only one systole that got blocked. If it is continuously blocked, then we have a heart block. But just one systole dropped because of the extrasystole. What do you see in this case? You'll see a P wave, which is earlier than it should be, and there'll be no QRS complex. Why? Because AV node did not conduct it. So see here, this is the P wave. It appeared earlier, right? So from that you can say, okay, this is an extrasystole. This is a supraventricular arrhythmia. But then you see there is no QRS complex. Why? What happened? Mr. AV node refused to conduct, and then after some time the next QRS complex and P wave came in. And don't worry that it looks a little dilated, because that's just me drawing it incorrectly. So that is the blocked atrial premature contraction, but blocked. And who blocked it? AV node. So once again, this is the explanation. You can read this if you like. Same thing as I discussed. So this is what we have for this lecture. Next lecture will be about the sustained supraventricular arrhythmias, which means continuous problem, and then we'll see how to manage them as well. Thank you very much.